Margaret Chen is 71 years old, retired school librarian from Columbus, Ohio. She's been taking Lisinopril every single morning for 6 years. Her blood pressure numbers look great on paper. Her doctor is pleased. But Margaret is not doing great. She's dizzy by noon, exhausted by 2 in the afternoon. She can't make it through a chapter of the novel she's reading without nodding off. She tells her daughter, "I think I'm just getting old." Her daughter doesn't accept that. She insists on a second opinion. And when the new doctor reviews Margaret's chart, he doesn't change her diagnosis. He changes her medication. What he found shocked both of them. And what happened next is something every single person watching this needs to hear. I'm Dr. Michael Carter, and if you or someone you love takes Amlodipine, Losartan, or Lisinopril, this video could genuinely change the way you think about your blood pressure treatment. Here's what I believe after years of working with older adults. These 3 medications save lives. That is not in question. But the way they are prescribed, dosed, and monitored in adults over 65 is often dangerously incomplete. And the side effects many seniors experience are being dismissed as just part of getting older, when they are actually the medication talking. Today I'm walking you through 6 critical things that most patients on these medications were never told. And I need you to stay with me for all 6, because number 3 is a side effect that millions of people are blaming on aging when it's actually their pill. And number 5 is the blood pressure number that sounds perfect on paper, but could be putting you in the hospital. If you take any blood pressure medication, or if someone in your family does, subscribe to this channel right now, because what we cover today could change the conversation you have at your very next doctor's appointment. Before we get into the list, I want to give you a framework, a way of thinking about everything that follows. I call it the dose assumption trap, and it works like this. Pillar 1. Your doctor prescribed your medication based on a clinical guideline. That is completely appropriate. But here's what most people don't realize. Those guidelines were built primarily on studies of 50-year-olds and 60-year-olds, not 78-year-olds with 3 other medications and a body that processes drugs very differently than it did 2 decades ago. Pillar 2. The dose that controls your blood pressure numbers on paper may be quietly creating symptoms you are blaming on age. Fatigue, dizziness, brain fog, swollen ankles. These are not inevitable parts of aging. They can be medication side effects hiding in plain sight. Pillar 3. Controlled blood pressure on your chart does not automatically mean optimal blood pressure for your body. A number that looks perfect in your file might be making your daily life worse. That's the dose assumption trap. Your numbers look fine, so everyone assumes your medication is fine, and no one asks how you actually feel. Keep this framework in your mind as we go through every single item on this list. Number 1, 3 drugs, 3 completely different mechanisms, and why it matters which one you're on. Robert Morales is 68, retired truck driver from San Antonio, Texas. When his blood pressure came back elevated at a routine physical, his doctor handed him a prescription for Amlodipine and said, "Take this once a day." Robert asked one question. "What does it do?" His doctor said, "It lowers your blood pressure." And that was the end of the conversation. Robert took that pill every day for 2 years without understanding a single thing about how it worked or why that specific drug was chosen for him. And that lack of understanding nearly cost him. Here's what Robert was never told, and what you may not know either. These 3 medications work in completely different ways inside your body. Amlodipine is a calcium channel blocker. It relaxes the muscles in your blood vessel walls, allowing them to widen so blood flows through with less pressure. Losartan is an angiotensin receptor blocker, or ARB. It blocks a specific hormone that tells your blood vessels to tighten up. And Lisinopril is an ACE inhibitor. It prevents your body from producing an enzyme that creates that same vessel-constricting hormone. Why does this matter? Because each of these classes carries a different set of side effects, different drug interactions, and different risks that become more significant as you age. Knowing which one you're on isn't trivia, it's essential. So here is your first action step. Ask your doctor this question at your next visit. Why did you choose this specific medication for me and not one of the other classes? If you don't get a clear, specific answer, that's a conversation worth continuing. And that side effect profile is where things get uncomfortable, especially for one of these three drugs. Number 2, the side effect your doctor calls normal that is anything but normal. Linda Hargrove is 73 years old, former postal worker from Richmond, Virginia. She's been on Amlodipine for 4 years, and for most of those 4 years, her ankles have been swollen. Not a little puffy, swollen enough that she stopped wearing the shoes she'd worn her entire adult life. She brought it up to her doctor at least twice. Both times the answer was the same. That's a common side effect. It's harmless. Don't worry about it. Linda trusted that answer. She adjusted. She bought wider shoes. She elevated her feet every evening. She accepted it. Until one afternoon when the swelling got so bad, her daughter took her to urgent care, and they discovered the edema was masking a deeper circulatory problem that had been developing, unmonitored, for over a year. This is not rare. The Journal of the American Heart Association has documented that amlodipine-related peripheral edema affects up to 10% of patients, and the incidence increases significantly with age and higher doses. In clinical settings, it is routinely trivialized, but here is the mechanism that makes it more than cosmetic. Calcium channel blockers like amlodipine dilate your arteries, but they do not dilate your veins at the same rate. That imbalance causes fluid to leak from the capillaries into the surrounding tissue. In younger patients, the body compensates. In older adults who already have reduced venous return, this creates a cascade. Swelling leads to reduced mobility. Reduced mobility leads to further circulation decline. And further circulation decline leads to increased fall risk. That is not harmless. If you have swollen ankles on a blood pressure medication, do not simply accept it. Request a full medication review. Alternatives exist. Switching to an ARB, adjusting the dose, or combining lower doses of 2 different classes can often solve the problem. Never accept "it's normal" as a final answer when a side effect is changing how you live. If you or someone you love has dealt with swollen ankles from a blood pressure pill, type "swelling" in the comments right now. I want to hear your experience. But amlodipine isn't the only one hiding something. If you're on Lisinopril, what comes next might sound painfully familiar. Number 3, the cough that won't quit, and what it's really telling you. James Whitfield, 69, retired electrician from Knoxville, Tennessee. 3 months after starting Lisinopril, James developed a dry, persistent cough. Not a cold, not allergies. A tickle in the back of his throat that turned into a cough that simply would not stop. He went to a pulmonologist. He got a chest x-ray. He even lay awake some nights worrying about lung cancer. For 8 months, not a single doctor he visited asked him one simple question: what medications are you taking? This is not a rare side effect. ACE inhibitor-induced cough affects up to 15% of patients, and some population studies put the number even higher. The New England Journal of Medicine has reviewed the mechanism extensively. Lisinopril blocks the enzyme that breaks down a substance called bradykinin. When bradykinin accumulates in the lungs, it irritates the airways and triggers a persistent dry cough that no amount of cough medicine will fix. And in older adults, this cough is not merely annoying. It disrupts sleep. It causes dizziness and lightheadedness during coughing spells. It increases fall risk. And it erodes quality of life in ways that are hard to measure but impossible to ignore. If you have developed a new, unexplained cough after starting an ACE inhibitor like Lisinopril, tell your doctor immediately. Switching to an ARB like Losartan eliminates this problem in the vast majority of patients. This is a known, well-documented, completely solvable issue. It is not something you should ever be told to just live with. Now, Losartan might sound like the safer bet after hearing all of that. But number 4 is the hidden landmine that Losartan patients specifically need to hear. Number 4, the silent potassium problem that nobody is checking. I'm not going to walk through a single case study for this one, because the hospital data tells a story that is far more alarming than any one patient's experience. Both ARBs like Losartan and ACE inhibitors like Lisinopril have a well-documented effect that receives far too little attention in routine care. They can elevate your potassium levels. The clinical term is hyperkalemia, and the data from the American Journal of Kidney Diseases shows that hyperkalemia-related hospitalizations in older adults taking these classes of medication are alarmingly common and increasing. Here is the mechanism. These drugs reduce a hormone called aldosterone. Aldosterone is the signal that tells your kidneys to excrete potassium. Less aldosterone means less potassium leaves your body. Now add the reality of aging. Kidney function naturally declines as we get older, which means your kidneys are already less efficient at clearing potassium. Then add what many seniors are eating: bananas, spinach, potatoes, sweet potatoes, beans, all promoted as heart-healthy foods, all extremely high in potassium. Then add potassium-containing supplements or salt substitutes that many health-conscious adults use without thinking twice. The accumulation can become dangerous. And here is the part that scares me most. Hyperkalemia often presents with no symptoms at all until it triggers a cardiac arrhythmia, a potentially fatal heart rhythm disturbance, with no warning. What to do instead? If you are on Losartan, Lisinopril, or any medication in the ARB or ACE inhibitor class, you need your potassium levels and kidney function checked regularly, at minimum every 6 months. This is not optional. It is essential monitoring that too many patients are not receiving. At your next appointment, ask one question: when was my potassium last checked? If no one can give you a clear answer, that is a problem. If you've been on one of these medications for more than a year and have never had your potassium levels tested, type "never" in the comments. I think you'll be surprised how many of us are in the exact same situation. But here's the one that scares me the most as a physician, and it's the one that almost no one is talking about openly. Number 5, the blood pressure number that's actually too low, when your medication becomes the danger. Dorothy Flanagan is 76, retired teacher's aide from Scranton, Pennsylvania. Her blood pressure was what her doctor called perfectly controlled, 118/70. Every visit, her doctor smiled and said, "Numbers look great, Dorothy." And Dorothy smiled back. But Dorothy was falling, twice in the kitchen, once in the driveway where she scraped both palms on the concrete trying to catch herself. And then one Tuesday morning, her daughter found her on the bathroom floor. She'd stood up, the room went black, and she went down. The emergency room diagnosis was orthostatic hypotension. Her blood pressure was plummeting every single time she stood up. The medication that was supposed to protect her heart was putting her bones and her brain directly at risk. The data on this is compelling and growing. Follow-up analysis of the landmark SPRINT trial, along with a widely cited 2023 study in JAMA Internal Medicine, found that intensive blood pressure lowering in adults over 75, pushing systolic pressure below 120, was associated with significantly increased rates of falls, fainting, acute kidney injury, and dangerous electrolyte imbalances. The American Academy of Family Physicians has recommended relaxed blood pressure targets for adults over 75, suggesting that systolic pressure below 150 may be more appropriate for many patients with multiple health conditions. Let me walk you through the cascade, because this is the one I need you to truly understand. Medication lowers blood pressure aggressively. You stand up from a chair or get out of bed. Blood pools in your legs because your vessels can't constrict fast enough to compensate. Your brain receives insufficient blood flow. You feel dizzy. Your vision dims. You reach for something to steady yourself. You miss. You fall. You fracture a hip. Surgery follows. Then a hospital stay, where hospital-acquired infections are common. Then prolonged immobility. Then muscle loss, cognitive decline, depression. One perfectly controlled number on a chart can trigger this entire chain of events. And it starts with a blood pressure reading that everyone in the room thought was good news. Here is what to do. Ask your doctor to check your standing blood pressure, not just your seated blood pressure. Request orthostatic vitals at every single visit. And have an honest conversation about whether your blood pressure target is appropriate for your age, your fall history, and your overall health. because a systolic reading of 140 might be genuinely safer for you than 118. The best number is not always the lowest number, which brings us to the conversation that ties all of this together, and the one tool I want you to walk away from this video holding in your hand. Number 6, the blood pressure medication checkup. 5 questions to bring to your next appointment. I want you to screenshot this, write it down, print it out, bring it with you. These 5 questions could change the way your blood pressure is managed. Question 1. Why am I on this specific medication and not another class? You deserve to know why Amlodipine was chosen over Losartan, or why Lisinopril was chosen over an ARB. The answer should be specific to you, not generic. Question 2. What is my blood pressure when I'm standing, not just when I'm sitting? A reading taken only while seated gives you half the picture. The other half could save you from a fall. Question 3. When were my potassium and kidney function last tested? If you're on an ACE inhibitor or ARB and no one is monitoring these numbers regularly, that is a gap in your care that needs to close immediately. Question 4. Is my current blood pressure target appropriate for my age and overall health? The right target for a 55-year-old is not automatically the right target for a 78-year-old. This question opens a conversation that many doctors don't initiate, but will respect you for starting. Question 5. Are any of my other medications or supplements interacting with this one? Blood pressure medications do not exist in isolation. NSAIDs, certain antidepressants, potassium supplements, even some over-the-counter cold medications can interfere with or amplify the effects of what you're taking. Any physician who takes your health seriously will welcome these questions. They will respect you more for asking them. And if your doctor dismisses you for raising these concerns, that tells you something important about whether that relationship is serving your health. Let me come back to Margaret Chen, the woman from our opening who thought she was just getting old. Her new doctor didn't change her diagnosis. He lowered her dose and switched her medication class. Within 3 weeks, the dizziness stopped. The fatigue lifted. She told her daughter, "I feel like I got 2 years of my life back." Margaret's blood pressure is still well controlled. But now, the number on the chart and the life she's actually living finally match. Here's what I want you to carry with you. A blood pressure pill should help you live better, not just live longer. If your medication is controlling a number on a chart, but quietly stealing your energy, your balance, your clarity, and your confidence, that is not treatment. That is a trade-off you never agreed to, and you have every right to question it. The best blood pressure for you isn't always the lowest one. It's the one that lets you live. If you are on any blood pressure medication, I want to hear your story. What are you taking? And has anyone ever sat down with you and asked whether it's still the right fit? Tell me in the comments. Your experience could help someone watching this right now who is going through the exact same thing. And if this video made you think differently about your treatment, share it with someone you love. Subscribe so you don't miss what's coming next. I'm Dr. Michael Carter, and I'll see you in the next one.